Good morning. So today we speak something about the gingival recession. What are the contents we are explaining in the recession is introduction, the definition, the prevalences, etiology of the recession, how it causes. So how can we classify a recession? What are the drawbacks of this classification? Pathogenesis of the recessions. How can we monitor recession? And what are the treatment modalities that you will take to cover the recession area? And class conclusion. Introduction. We all know that all the individuals that will increase concern about their smile and are particularly unhappy when they have aesthetic issues and pain associated with exposed foods. You can have a healthy mouth and practice good oral hygiene and yet experiences a condition called as gingival recession. In healthy patients, the recession is mainly seen due to extra oral care that we are providing, whereas recession seen in periodontic disease patients is likely due to chronic inflammatory processes that may represent years. Too much of things is for a good thing, right? So because in a healthy patients, you are carrying so much for oral cavity, so much you are brushing it, more chances of getting a recession. Doing too little is also a good thing. Now, we're coming to the definition of the gingival recession. The gingival recession is defined as an apical shift of the gingival margins to a position that is apically to the cemento-enamel junction with exposure of the wood surface to the oral cavity. It's given by Casaubon and Cohen. Gingival recession is also characterized by the displacement of the gingival margins apically from the cemento-enamel junction or from the former location of the cemento-enamel junction in which the restoration have distorted the location or appearances of cemento-enamel junction. That means there is a displacement. The gingival margin is displacing apically from the cemento-enamel junction. Recession can also be a localized or generalized, that is presenting in a single tooth as well as presenting in almost more than 5, 6, 7, 8, etc. and can be associated with one or more surfaces given by Smith. It has been estimated that 50% of the population has one or more sites with 1 mm of such exposures. This prevalence rate is increasing to greater than 88% for individuals who are 65 years old, increasing in the age, increasing in the causing of recession. It's more common, given by Cassett. Another person, Albender and Kingman, they reported epidemiological data is on 9,680 subjects in the year between 30 to 90 years of age. They found that the prevalence of the recession of 1 mm or more of this population of 58%, that is increasing with age. There's another study by National Health Center from 1988 to 1991. Actually, they revealed around 7,447 subjects, a 15% prevalence of gingival recession that is more than or equal to 3 mm. Prevalence that is varied from 0.5% samples with 18 to 24%. Susan et al. Also found a prevalence of gingival recession in the Brazilian population, with more than half of the individuals they presenting is more than 3 mm recession defects. So what are the etiology of recession? What are the causes? Mainly they told us there are 2 factors, predisposing factors and precipitating factors. And another 2 more factors are the cofactors and determinant factors. So first one is a predisposing factors. It is inadequate attaching gingiva, mainly inadequate. Why this is inadequate? Because of high finger attachments or the shallow vestibule. Then the malpositioning of the teeth, especially the prominent roots and osseous dehiscences. And precipitating factors, vigorous brushing, lacerations, recurrent inflammations, and iatrogenic factors. Determinant factors and cofactors. The determinant factors, first one is the bacterial plaque. Ollier et al. They found a direct correlation between the increasing of the plaque index and increase of the margin tissue recession. Increasing in the deposits of the local factors such as plaque related to more chances of getting recession. Second one is trauma from the tooth surface, tooth brushing, improper techniques and wrong tooth brushing. Third one is iatrogenic factors like filling of amalgam or prosthetic overhang of respirations, clamps, orthodontic appliances, as well as habits, the finger or any foreign objects, fingernails, biting, nail biting, etc. One of the cofactors mainly the malposition of the tooth. Suppose there is a more buccally placed tooth resulting in altered tooth-bone relationship. Second one is unfavorable anatomy, frenal insertion, cerebral fold, and the third one is orthodontic movements. The major causes of recession is depend upon their factors such as aging, anatomical factors, physiological factors, pathological factors, oral hygiene habits, and iatrogenic factors. So first we'll go through aging. Wofter, they found out that gingival recession in the third to fourth decades of life, in addition to males, have been found to have increased recession compared to females, and black males have more recession as compared to Caucasian males. Government found that the frequency of gingival recession increases with age and it's greater than an improvement of the same age. Moreover, they examined 4,000 subjects and found that the incidence of recession increases with age. Next is an anatomical factors. While the recession is largely preventable, it is known to be exacerbated in the presence of certain anatomical factors. The anatomical factor most commonly correlated with gingival recession is a narrow band of keratinized gingiva, given by lag and low. Next is an alveolar bone. Dehiscences, high frenal attachments, and the gingival dimensions are the anatomical factors that causes the gingival recession. The buccal alveolar bone provides much of the local blood supply for the buccal gingiva. The loss of underlying bone is associated with the loss of the buccal gingiva. Thin, fenestrated, or absent alveolar bone disposes the site to gingival recession, a phenomenon that frequently occurs on the labial surface of canines and premolars and the mesial roots of molars. The tooth anatomy, apparent part of eruption or the position also affects the alveolar bone thickness. Facially positioned teeth more likely to be affected. Crowding in the lower anterior segment increase the risk of gingival recessions, especially the buccally placed lower anteriors having more chances and more risk of getting a gingival recessions. Next is the pathological cause. The pathological cause mainly depend upon the inflammation. That is, localized inflammation is theorized to be another major cause of recession, given by Baker and Singer in 1976. Patient who have a thin biotype or a sensitive tissue are especially susceptible to this type of recession. It is theorized that the local inflammation, whether due to the plaque or trauma, can sometimes involve the entire width of a gingiva. The epithelium may then proliferate and overcome the connective tissues that resulting in the recession. This is likely the primary etiology for recession commonly found around the supragingival calculus and the overhanging restorations, where the plaque accumulation at such sites are easily exacerbate the local inflammation. Next is oral hygiene habits, that is overzealous toothbrushing. Clinical studies, what they reported is that more of the gingival recession with good oral hygiene improve oral hygiene status. Indeed, the most brushed teeth with the lowest plaque scores exhibit the most gingival recession, which has to be linked to a description of the gingival recession and insensitivity as well as toothbrush diseases. What are the most common location of the recession? They are facial aspects of canines, premolars, and molars. What we found out, the most commonly found out tooth recession is canines, followed by a premolars, then come back to the incisors and the molars. Interestingly, a significant higher proportion of the left versus right contralateral teeth were reported in white-haired patients. The patient is using brushing by right-handed, mostly the left side will be affected with the recession and more affected the left side. In the case of right-handed people, more recession is seen on the left half of an upper and lower facial surface according to Adiata, but conversely, on the right side according to Tesserator, regardless of side affected, recession is associated with vigorous or improperly executed brushings. Next is identifies abrasivity. That is the most common causes right now. They are discussing about possible gingival recession. Although the relation is not well documented, it identifies the higher level of abrasive ingredients. Also causes the soft tissue damages to its mainly given by IDHR in 2003. Next one is a traumatic tongue and the lip rings that causes trauma to the marginal tissues, marginal gingiva, as can cause an damage from scaling or other dental treatments and affects the habits such as using toothpicks inappropriately or scratching the gingiva with fingernails or other devices. The type of physical injury to a gingival tissues is self-inflicted. Sometimes the mention is called as gingivitis artifact. Self-inflicted gingival injuries in children and in adolescents can occur as a result of accidental trauma, premedicated inflammation, premediated infection, or chronic habits such as fingernail biting, digital sucking, or sucking on objects such as pens, pencils, etc. And the last one is iatrogenic, mainly done caused by an orthodontic movements. This orthodontic movement of teeth is a position outside the labial or lingual completely due to deficient formations. The labial movement of the teeth resulting in loss of alveolar buccal plate followed by gingival recession. Restorative dentistry, the crown preparation is one of the important factors that will cause recession, extending the subgingival and impression techniques involving the gingival retraction cords may be the reason for the ocular gingival recession. Donaldson in 1973. Regarding the presence of restoration class 5 or crown, it is well known that failed adaptation of the membranes can lead to gingival recession. Overhanging of restorations promote the gingivitis, promoting the local accumulation of the bacterial plaque and calculus, and that restorations are placed below the gingival membranes, detrimental to gingival recession. Next is prosthetic dentistry. This is poorly designed partial dentures that can cause gingival recession. Apartment to after this etiology, causes of recession, we go back to the classification of recession. Classification given by Sullivan and Atkins in 1968, with P.D. Miller's classification, margin tissue recession 1985, Lennick et al. In 1973, Vincu et al. In 83, and Smith index for recession in 1997 for the laws of capillary height norm, and Darwin also given a recession classification in 1998. Sullivan and Atkins in 1968, they give classification shallow narrow, deep narrow, shallow wide, and deep wide. Lennick et al. In 1973, reporting that the results of root coverage with mucosal grafts quantified. Shallow narrow cleft has been less than 3 mm in both dimensions, and deep void defects has been more than 3 mm in both the directions.